preferred because the linea alba only has small vessels and nerves, so there's a lower risk of bleeding and nerve damage. A paramedian incision, which is lateral to the median plane, is made in a sagittal plane and can extend anywhere from the costal margin to the pubic hairline. The paramedian incision would therefore go through the anterior rectus sheath, the rectus abdominis muscle, and the posterior rectus sheath. Gridiron incision, and the Rutherford-Morrison incision. So first, the McBurney incision is typically needed for appendectomies, and it's done inferomedially in an oblique orientation to follow the anterior superior iliac spine to the umbilicus. Instead of an oblique incision, surgeons can also use Rutherford-Morrison incision, which is an oblique incision used for right and left-sided colonic resection. Instead of an oblique incision, surgeons can also use transverse incisions, which are often made through the anterior layer of the rectus sheath and rectus abdominis muscle. They provide good access and are less likely to damage the nerve supply of the rectus abdominis as the incision is parallel to the nerves, and are used in pediatric or vascular repair cases. Another type of transverse incision is a Lanz incision, which may also be used for appendectomies and is located in the right iliac fossa and has a more transverse orientation. These types of incisions leave the anterior branch of the iliohypogastric nerve at risk of injury, which would cause decreased sensation over the suprapubic region. Next, horizontal with a slight convexity and are used for most gynecological and obstetrical operations, like a cesarean section. Once this incision is made, the linea alba and anterior rectus sheath is resected, and the rectus muscles are retracted laterally. Care must be taken not to damage the iliohypogastric or ilioinguinal nerves, as damage to these could result in sensory deficits of the suprapubic and genital region. Sometimes, during a cesarean section, there isn't enough space to properly finish the procedure and take the baby out safely. In this case, a horizontal transection of the rectus abdominis muscle might be done in addition to the vertical incision along the linea alba. In order to perform a horizontal incision, first you need to locate the arcuate line, which lies below the umbilicus posterior to the rectus abdominis and marks the inferior limit of the posterior rectus sheath surface to enter the lateral aspect of the muscle at the arcuate line. Since there's no supporting posterior rectus sheath below the arcuate line, this is where the inferior epigastric arteries are most susceptible to injury, so they need to be located and ligated when performing a horizontal incision in order to prevent significant hemorrhage. Now, bear in mind that any abdominal surgery comes with a risk of nerve injury. The inferior thoracic spinal nerves, those from T7 to T12, and the iliohypogastric and ilioinguinal nerves provide innervation of the abdominal muscles. They are distributed across the anterolateral abdominal wall where they run oblique, but mostly horizontal. They can be injured during any surgical incision or from trauma at any level, leading to muscle weakness of that area of innervation. Muscle wall weakness can lead to herniation of underlying abdominal viscera through the abdominal wall. In addition to a general inspection of the abdominal wall, another key step in clinical examination is abdominal palpation, which is when you palpate the abdominal wall and the abdominal viscera while the individual lies in a supine position with exposure from their nipples to their pubic symphysis. One clinically relevant sign to look out for when palpating the abdomen is guarding, which is when the muscles of the abdomen get tense and produce spasms. Guarding can be either voluntary or involuntary. Voluntary guarding is a voluntary contraction of the abdomen performed by the patient in order to avoid pain during examination and usually represents a diffuse abdominal pain, meaning the entire abdomen tenses up. Involuntary peritonitis, or an inflammation of the abdominal peritoneum. This is often an indication of an acute abdomen, which is the sudden onset of severe abdominal pain, and why abdominal palpation is so important during a clinical exam. Next up, we're going to look at the psoas major muscle, which originates along the anterior surface of the transverse processes and lateral surface of T12 to L5 vertebral bodies, and eventually combines with the iliacus muscle to form the iliopsoas muscle. The main clinical condition affecting the psoas major muscle is a psoas abscess, which is a walled-off collection, typically pus-filled, found along the psoas fascia. This can be caused by things such as spread of infection from the thoracic or as well as hematogenous seeding from a distant associated diabetes, IV drug use, HIV infections, and other forms of immunosuppression, thigh or knee joint. Other symptoms of a psoas abscess include fever and difficulty walking. A psoas abscess may be visualized and palpated in the inguinal region and may be mistaken as an inguinal hernia, an enlarged lymph node, or a saphenous vein varix. Furthermore, it is important to note the femoral nerve emerges laterally between the psoas major muscle and iliacus muscle, so an abscess can result in femoral neuropathy and quadriceps weakness, decreased patellar reflex, as well as sensory loss over the anterior and medial thigh and leg. To test for a psoas abscess, you can perform the iliopsoas test, which is when the individual is asked to lie on the unaffected side and a contralateral hip is put into extension by the examiner. A positive sign is when pain appears during movement and can indicate a psoas abscess. Other things that can cause a positive psoas sign are an inflamed or infected appendix, sigmoid colon, and iliac lymph nodes. Another important structure located along the posterior abdominal wall is the inferior vena cava, or IVC for short. The IVC ascends in the abdomen along the right side of the vertebral bodies to the right of the abdominal aorta. On a coronal section of a CT scan, however, the IVC can be seen along the vertebral bodies, but on the left side of the image, which corresponds to the right side of the body. This is because when looking at a transverse slice of a CT or MRI scan, we are viewing the section from below, which is why the structures on the right-hand side of the body are shown on the left-hand side of a transverse radiology scan, and vice versa. Sometimes an IVC filter, which is a tiny device able to stop blood clots and prevents them from traveling towards the heart and lungs, needs to be placed within the IVC. To do this, a long catheter is placed by surgeons through the internal jugular vein or the femoral vein until it reaches the inferior vena cava. The main indication for placing an IVC filter in someone is to prevent embolization of deep venous clots from the legs to the lungs, which would cause a pulmonary embolism. An IVC filter is often used in patients who have contraindications to anticoagulation, typically those who are at an increased risk of bleeding. Now, before we wrap up, let's look at abdominal aortic aneurysms, which is defined as a pathological dilation of the aorta usually greater than 50% of the normal aortic diameter. Typically, the normal infrarenal aortic diameter is 2.0 centimeters, and an aneurysm is considered anything larger than 3.0 centimeters, where a large aneurysm is defined as over 5.5 centimeters in diameter. Risk factors include being a biological male, old age, cigarette smoking, hypertension, a family history of abdominal aortic aneurysms, and last but not least, atherosclerosis. Even though atherosclerotic buildup contributes to the formation of abdominal aortic aneurysms, the pathophysiology of an abdominal aortic aneurysm is complex and involves systemic inflammation, as well as smooth muscle cell apoptosis and extracellular matrix degradation, resulting in thinning and weakening of the aortic wall and enlargement in aortic diameter. The most common location of an abdominal aortic aneurysm is just below the renal arteries and is referred to as an infrarenal aneurysm. Now, the majority of abdominal aortic aneurysms are asymptomatic, but people can also present with abdominal pulsations, compression of surrounding structures, abdominal, back, or flank pain, and if the aneurysm ruptures, it leads to severe abdominal pain, along with a pulsatile mass in the abdomen and arterial hypotension. Okay, let's take a look at this coronal section of a computed tomography scan. Can you see the balloon-shaped structure in front of the vertebral body? That's the dilated abdominal aorta. In a CT or MRI cross-sectional scan, the aorta is found on the right-hand side of the vertebral bodies in the image, which actually corresponds to the aorta being on the left-hand side of the vertebral bodies in the individual being scanned. All right, as a quick recap, different surgical incisions are used to access the abdomen for different surgical procedures. These include Coker or subcostal incision, median or paramedian incision, the McBurney or gridiron incision, as well as the Lanz, Pfannenstiel, and Rutherford-Morrison incisions. During abdominal surgery, the inferior thoracic spinal nerves, as well as the iliohypogastric and ilioinguinal nerves, can be injured. During a horizontal transection of the rectus abdominis muscles, the inferior epigastric arteries need to be ligated to avoid hemorrhage. Voluntary guarding is a voluntary contraction by the patient of the abdomen in order to avoid pain during examination and is usually diffused over the entire abdomen. Involuntary guarding, or rigidity, happens when there's involuntary contraction of the abdominal muscles, usually caused by peritoneal inflammation, and indicates an acute abdomen. The iliopsoas test can be used to indicate certain abdominal pathologies, such as psoas abscess, appendicitis, or irritation to nearby structures. A psoas abscess happens when there is a walled-off collection, typically pus-filled, found along the psoas fascia. IVC filters are placed to prevent emboli from reaching the heart and the lungs. Aortic abdominal aneurysms are dilations of the abdominal aorta that are usually infrarenal. Symptoms of a ruptured aneurysm can include severe abdominal The abdominal cavity is home to plenty of organs. Some of them, like the stomach, simply means increased pressure in the portal venous system. This is most commonly caused by liver cirrhosis, or compression of the in the liver from cirrhosis obstructs the portal vein. The pressure rises in the portal vein and into its tributaries. This large volume of congested blood flows out from the portal system into the systemic system at the sites of portosystemic anastomoses, also called portocaval anastomoses. The first site of portosystemic anastomosis is at the lower esophagus. At this point, the high pressure in the portal system can reach the anastomosis between the left gastric veins and the esophageal veins in the lower esophagus, causing engorged varicose veins, which may then go on to rupture and lead to upper gastrointestinal bleeding. In more severe cases of portal hypertension, the veins of the anterior abdominal wall, called the epigastric veins, which anastomose with the paraumbilical veins, become varicose and look like small snakes radiating from the umbilicus under the skin. This clinical sign is called caput medusae. There is another portosystemic anastomosis in the rectum, which in the case of portal hypertension can lead to anorectal varices. Some other signs and symptoms of liver cirrhosis include palmar erythema, petechiae, ascites, and jaundice. These might be present in addition to the signs of portal hypertension and symptoms of liver cirrhosis, which in the case of portal hypertension can lead to anorectal varices. Some other signs and symptoms of liver cirrhosis include palmar erythema, petechiae, ascites, and jaundice. These might be present in addition to the signs of portal hypertension as we discussed, anorectal varices, caput medusae, and esophageal varices. Now let's talk about the gallbladder, which is often affected by gallstones. Gallstones are tiny stones that form in the gallbladder, and the technical term for these gallstones in the gallbladder is cholelithiasis. To understand the clinical repercussions of gallstones, let's review the anatomy of the hepatobiliary tree and the pancreatic ducts. So the liver cells, called hepatocytes, secrete bile, and the bile drains from the hepatocytes through bile canaliculi to the interlobular biliary ducts, then the collecting bile ducts, and finally into the right and left hepatic ducts. The right and left hepatic ducts then join to form the common hepatic duct. Also, the gallbladder has its own duct called the cystic duct. The common hepatic duct meets the cystic duct, and they join together to form the common bile duct. The common bile duct then descends and passes posterior to the first part of the duodenum and the head of the pancreas. At this point, it converges with the main pancreatic duct, and together they form the hepatopancreatic ampulla, or ampulla of Vater, which empties into the duodenum. Now, gallstones are mainly made of cholesterol crystals, and they arise from the biliary tree. When a gallstone blocks the cystic duct, it obstructs the passage of bile from exiting the gallbladder. In this case, contraction of the gallbladder, like after a fatty meal, can lead to biliary colic, which is an intense spasmodic pain located in the right hypochondrium or right upper quadrant. When the gallbladder relaxes, the stone might move back into the gallbladder, relieving symptoms. Alternatively, it can remain lodged in the cystic duct, and this causes inflammation and enlargement of the gallbladder, known as cholecystitis. Symptoms of cholecystitis include right upper quadrant pain or epigastric pain, along with anorexia, nausea, vomiting, and fever. Since the stone is only obstructing the gallbladder from emptying via its cystic duct, while the common bile duct remains open, patients with cholecystitis do not often present with jaundice. On clinical examination, there's a positive Murphy sign. This is when the individual is asked to take a deep breath while the doctor palpates the area of the gallbladder just beneath the edge of the liver. Deep breaths cause the gallbladder to descend and press against the examining fingers, which in individuals with acute cholecystitis leads to pain and discomfort. A positive Murphy sign is when the patient catches their breath and ceases to inspire due to the pain of the inflamed gallbladder descending against the examiner's hand. Gallstones can also migrate and obstruct the common bile duct, small intestine, to multiply within the common bile duct. This situation is called ascending cholangitis, a fancy term for the common bile duct is obstructed, inflamed, and bacteria are wreaking havoc inside. Symptoms of ascending cholangitis include fever, abdominal pain, and jaundice, also known as Charcot triad. Jaundice occurs due to the obstruction of the common bile duct and subsequent buildup of bilirubin in the liver and then in the blood. Interestingly, gallstones can also migrate to where the common bile duct meets the pancreatic duct at the ampulla of Vater and obstruct both the common bile duct and the main pancreatic duct. This obstruction of the pancreatic ducts leads to pancreatitis, which is the inflammation of the pancreas. Symptoms of pancreatitis include anorexia, malaise, and epigastric pain, which often radiates to the back. With the gallstone obstructing the common bile duct at the same time, patients often appear jaundiced as well. Finally, an enlarged and inflamed gallbladder can attach itself to and form communications with adjacent viscera, and these are called fistulae. For example, a cholecystoenteric fistula is when a communication between the gallbladder and the intestine forms. The location of the gallbladder affects which organs are most likely to develop a fistula with it. These organs are the superior part of the duodenum and the transverse colon. A large enough gallstone won't be able to enter and pass through the cystic duct, but it could pass through a cholecystoenteric fistula and enter the gastrointestinal tract. Such a stone can then travel distally and become trapped at the ileocecal valve, causing small bowel obstruction. This particular type of bowel obstruction is called a gallstone ileus. Symptoms include recurring diffuse abdominal pain and vomiting. Air from the intestinal tract may also enter the biliary tree through this fistula, leading to pneumobilia, which can be detected on imaging. Luckily, a cholecystectomy, which is when the gallbladder is surgically removed, can be done to manage several gallbladder issues, some of which we've just discussed. Surgery ultimately depends on the patient's clinical symptoms and surgeon preference, but reasons for cholecystectomy include choledocholithiasis, gallstone pancreatitis, uncomplicated cholecystitis, acalculous cholecystitis, porcelain gallbladder, gallbladder polyps larger than 0.5 centimeters, as well as asymptomatic cholelithiasis in individuals at increased risk for developing gallbladder cancer. During surgery, it's important to identify callow triangle or the cystohepatic triangle in order to superiorly by the inferior surface of the liver. The cystic artery is located within the triangle and is identified during a laparoscopic procedure and then ligated or clipped off. The triangle also contains the right hepatic artery and might contain anomalous bile ducts. Because of this, ligation of the cystic artery should only happen once the boundaries of callow triangle have been identified and the structures passing through it have been dissected and identified. During cholecystectomy, the common bile duct can be damaged, which can lead to leakage of bile into the abdomen and consequent peritonitis. The surgical instruments used to remove the gallbladder can also injure other structures, like the intestine and surrounding blood vessels. Before moving on, a quick quiz. What can happen when a gallstone migrates to the common bile duct? Now, let's have a quick chat about the spleen and the pancreas. The spleen is an intraperitoneal organ that lies in the left hypochondrium close to other intraperitoneal organs like the stomach, the transverse colon, and the descending colon. It's also close to the left kidney and the pancreas, both of which are retroperitoneal organs. In most individuals, the spleen doesn't extend inferiorly past the rib cage unless it's enlarged. The spleen is the most commonly injured organ during blunt trauma, for example by car crashes, sports injuries, and fistfights. Splenic injuries can occur due to fracture of the overlying ribs or impact to the spleen itself and can range from a simple contusion or subcapsular hematoma to splenic laceration and subsequent internal bleeding. Individuals with a ruptured spleen can present with nausea, abdominal pain, abdominal guarding, tenderness in the epigastrium, and pain in the left flank, as well as hypotension or shock due to profound intra-abdominal bleeding from this highly vascular organ. Moreover, a ruptured spleen can present with a positive Kerr sign, which is when there's referred pain, typically to the upper left shoulder due to irritation of the phrenic nerve in the diaphragm. A ruptured spleen is considered a surgical emergency and must be addressed as soon as possible. In most cases, a ruptured spleen requires a splenectomy, which is the surgical removal of the spleen. And now for the pancreas, which is an elongated, digestive gland that lies in the retroperitoneum, crossing the bodies of the L1 and L2 vertebra on the posterior abdominal wall. It lies posterior to the stomach, between the duodenum on the right and the spleen on the left. One of the most important diseases of the pancreas is pancreatic cancer, of which pancreatic adenocarcinoma is the most common type. Symptoms of pancreatic cancer include weight. Abdominal pain is usually located in the epigastrium and can radiate to the back or sides. Jaundice may happen as a result of obstruction of the nearby biliary tree by the tumor or by metastasis. Pancreatic cancer can also invade major arteries, like the superior mesenteric artery, which is posterior to the neck of the pancreas. In patients with suspected biliary obstruction and jaundice, Courvoisier's law states that an enlarged and non-tender gallbladder accompanied by mild jaundice is unlikely to be caused by gallstones and is more likely caused by pancreatic or gallbladder cancer. Accompanied by mild jaundice is unlikely to be caused by gallstones and is more likely caused by pancreatic or gallbladder cancer. Finally, it's worth mentioning that the tail of the pancreas passes anterior to the left kidney and is closely related to the splenic hilum and left colic flexure. The pancreatic tail is mobile and can pass between the layers of the splenorenal ligament along with the splenic vessels. This is important because during a splenectomy, one complication of the surgery occurs when the tail of the pancreas is damaged. Postoperatively, patients may show biochemical markers of pancreatic injury and pancreatitis, and may also lead to the patient developing diabetes. Let's take a quick quiz. What can cause a positive Kerr sign? Where does it occur for a ruptured spleen? Let's finish off this video by discussing the abdominal organs that belong to the urinary system. The left kidney is usually located between the transverse processes of T12 and L3 vertebrae and is a bit more superior than the right kidney. Adjacent to the left kidney, there's the left 12th rib. Now, remember that rib fractures are the most common injury during blunt thoracic trauma. I hope you know where I'm going with this. If the 12th rib is fractured, then its distal tip can displace into the retroperitoneal cavity and cause a laceration of the left kidney. Okay, let's giddy up and talk about what's called a horseshoe kidney. In some individuals, during embryological development, the kidneys are fused anterior to the aorta and posterior to the inferior mesenteric artery. The root of the inferior mesenteric artery catches onto this isthmus and prevents the kidneys from relocating to their normal position, so this type of anomalous kidney usually rests in the lower abdomen. A horseshoe kidney is usually asymptomatic and is discovered incidentally during abdominal imaging. However, these individuals have an increased risk of ureteropelvic junction on a CT scan, recurrent urinary tract infections, renal calculi, and renal tumors. On a CT scan, we can identify renal tissue on both sides of the aorta connecting at the isthmus distal to the origin of the inferior mesenteric artery. This is still normal renal tissue, but with an abnormal configuration. Another important clinical concept is nutcracker syndrome, which is when the left renal vein is squeezed between the superior mesenteric artery and the abdominal aorta. Normally, the angle between the superior mesenteric artery and the abdominal aorta is around 45 degrees, and the renal vein is cushioned by a layer of fat in the mesentery. If this angle gets smaller, then the two arteries can compress the left renal vein. Precipitating factors include tumors like pancreatic and through the left renal vein, so the pressure rises in the left kidney, compromising kidney function. Since the left gonadal vein drains directly into the left renal vein, it will also become backed up. This can then lead to left testicular pain or left lower quadrant pain, especially during intercourse and menstruation. In rare cases, this backflow through the left gonadal vein can cause a varicocele in biological males, which is the enlargement of the venous plexus of the testicle. In biological females, venous congestion in the ovarian vein can lead to symptoms such as pelvic pain. Symptoms of nutcracker syndrome can include gross hematuria and left flank pain that might improve or get worse when changing positions. Finally, remember that urine leaves the kidneys through the ureters. Unfortunately, these organs can be affected by ureteric calculi, which are solid stones that get lodged inside the ureter. Anatomically, there are 3 locations where the ureters are the narrowest, so vesicle junction. When a stone is stuck in the ureter, this can lead to renal colic, which is described as an acute episode of severe flank and groin pain, often referred to. So the sensory fibers from the ureters enter the spinal cord at T11 through L2, therefore ureteric pain is referred to those dermatomal areas, which explains the sensation of loin to groin pain. Upper ureteric stones cause pain that radiates to the flank and lumbar areas. Mid-ureteric calculi cause pain that radiates anteriorly and inferiorly from the flank and lumbar areas. Distal ureteric stones cause pain that radiates to the groin and/or the testicles or labia majora. That's because the pain is referred through the ilioinguinal nerve, which originates at L1, and through the genitofemoral nerves, which originates at L1 and L2. Alright, as a quick recap, portal hypertension is increased pressure in the portal venous system, which can cause increased pressure in the portosystemic anastomoses. This can lead to esophageal varices, anorectal varices, and caput medusae. Gallstones are usually located in the gallbladder and are asymptomatic, but they can migrate and obstruct the cystic duct, the common bile duct, and even the pancreatic ducts, with each case causing specific symptoms and clinical outcomes. An enlarged and inflamed gallbladder can develop communications with adjacent viscera, like the intestine, and this is called a cholecystoenteric fistula, which can result in gallstone ileus, a type of small bowel obstruction. Cholecystectomy is the surgical removal of the gallbladder. The spleen is the most commonly injured internal organ during blunt trauma. Splenic injury ranges from a simple contusion or subcapsular hematoma to laceration and internal bleeding. A ruptured spleen may commonly present with a positive Kerr sign. Courvoisier's law states that an enlarged and non-tender gallbladder accompanied by mild jaundice is unlikely caused by gallstones and rather caused by pancreatic or gallbladder cancer. During a splenectomy, the tail of the pancreas can be damaged, causing issues such as pancreatitis and diabetes. A 12th rib fracture can displace anteriorly into the retroperitoneum and cause a laceration of the left kidney. When the kidneys fuse together at their lower poles, they form a big kidney called a horseshoe kidney because of its appearance. Nutcracker syndrome happens when the left renal vein is squeezed between the superior mesenteric artery and the abdominal aorta. Backflow of blood through the left gonadal vein, which drains into the left renal vein, may also occur, leading to pelvic symptoms in biological females and varicocele in biological ureters. And ureteric calculi are the presence of a solid stone, typically causing symptoms of pelvic junction, ureterovesical junction.
The inguinal region, located near the groin, is found in the lower part of the anterior abdominal wall, and it contains several important structures that enter and leave the abdomen. Understanding the anatomy of the inguinal region is important or tissue protrudes through the wall of the muscle or the inguinal region, through which subcutaneous fat, abdominal omental fat, or even linea alba, previous surgical interventions that weaken the abdominal wall muscles, or pregnancy. Umbilical or periumbilical, Spigelian, and incisional hernias. Epigastric hernias are caused by a weakened linea alba and are basically defects in the abdominal midline between the umbilicus and the xiphoid process. Then there are umbilical or paraumbilical hernias, which are hernias through the umbilical ring or around the umbilicus. These are often found in Spigelian hernias are found along the semilunar lines, which are skin folds from the inferior costal abdominal tissue can protrude. Muscle and fascia is typically weakened, for example, over the surgical site of an appendectomy pressure, or irreducible, which can't be pushed back. Irreducible hernias can become either incarcerated or strangulated. Incarcerated hernias are when the hernia contents are trapped and cannot be reduced, leading to swelling and edema of the herniated contents. With severe swelling, obstruction of blood flow to the herniated contents can occur, and this leads to ischemia and necrosis, resulting in strangulation. Incarceration and strangulation can affect any protruding structure with a blood supply, such as the omentum and bowel. Risk factors for developing a hernia include genetic hernia, may cause coughing or laphomatous skin changes of the recti. This is when there's a separation between the rectus muscles due to conditions, pregnancy, connective tissue disorders, or prior abdominal surgery. This particular type of hernia is not what we call a true hernia, because technically the midline fascial layer of the abdominal wall is intact. This means that strangulation doesn't occur. Individuals affected by rectus abdominis diastasis present with a midline abdominal ridge that becomes more obvious when increasing the abdominal pressure, and can disappear when the abdominal muscles are relaxed. Diagnosis is based on physical examination, and an abdominal ultrasound can be done to completely rule out a hernia. Time for a quick quiz. What are the 4 main types of anterior abdominal wall hernias? Now let's look at femoral and inguinal hernias, and lateral to the pubic tubercle and lacunar ligament. One important risk factor for femoral hernias is advanced age, as the femoral ring can widen with age. Femoral hernias also tend to be more common in biologically female individuals compared to biological males. But don't get confused, as inguinal hernias are a more common type of hernia in both biological males and biological females. Now, as the space in the femoral canal is limited, femoral hernias can often become irreducible and incarcerated, and subsequently can cause bowel obstruction if there is bowel located in the hernia sac. In time, this type of hernia can become strangulated and cause bowel ischemia and necrosis. On the other hand, there are two types of inguinal hernias: direct and indirect inguinal hernias, of the transversalis fascia. In this case, the hernia sac pushes through the weak portion of the transversalis fascia, above the inguinal ligament. Here, it protrudes into an area called Hesselbach triangle, which is bounded laterally by the inferior epigastric vessels, medially by the lateral wall of the rectus abdominis, and inferiorly by the inguinal ligament. You should note, direct hernias do not pass through the deep inguinal ring, and may only protrude through the superficial ring. Therefore, they have no direct route into the scrotum. Indirect hernias occur when the hernia sac emerges lateral to the inferior epigastric arteries, which is in contrast to direct inguinal hernias, and protrude through the deep inguinal ring into the inguinal canal, with the potential to extend distally into the scrotum. Indirect hernias are typically caused by a failure of the processus vaginalis to close in biologic males, or the deep inguinal ring to close in biologic females. Remember that the processus vaginalis is an embryonic structure that precedes the descent of the testes through the inguinal canal. Normally, after the testes have descended into the scrotum, this structure closes up, but in some cases it can remain open and allow for communication between the abdomen and the scrotum. Inguinal hernias are the most common type of hernia in both biologically male and female individuals, and they occur much more frequently in males. Direct inguinal hernias are more common in older individuals, where indirect ones are more common in infants. Compared to femoral hernias, indirect inguinal hernias are less likely to become strangulated, with direct inguinal hernias the least likely to become strangulated. Signs and symptoms of both femoral and inguinal hernias are a palpable bulge, often exacerbated by increased mass in the inguinal canal and scrotal sac. If a hernia becomes incarcerated and strangulated, for example during a femoral hernia, this can lead to overlying erythematous skin changes, as well as nausea, vomiting, clinical obstruction, and extreme pain. Anatomical landmarks. On clinical examination, femoral hernias are typically palpated lateral and inferior to the pubic tubercle. Both direct and indirect inguinal hernias occur above the inguinal ligament. Direct inguinal hernias push through the Hesselbach triangle, medial to the inferior epigastric artery, and may protrude into the superficial inguinal ring. So clinically, they can be palpated superficial or medial to the pubic tubercle. Finally, indirect inguinal hernias protrude lateral to the inferior epigastric artery, into the deep inguinal canal, located at the midpoint of the inguinal ligament, and may extend through the inguinal canal and into the scrotum. Therefore, they may be clinically palpated with deep palpation using the tip of the finger anywhere along the inguinal canal, medial to the pubic tubercle, where they exit the superficial ring, or along the spermatic cord and into the scrotum. However, keep in mind you still may be unable to identify which type of hernia is occurring based on the clinical exam alone. Okay, hernias can be resolved surgically with a procedure called herniorrhaphy, but sometimes complications arise. During hernia surgery, sometimes an artery called the aberrant or accessory obturator artery can be injured, typically coming from either the inferior epigastric artery or external iliac artery that is in or stapled. When this occurs, the artery retracts, making it very difficult to locate and ligate, leading to uncontrolled bleeding. This artery has been referred to as corona mortis, which means crown of death, as injury to it can be fatal. On the other hand, during inguinal hernia repair, more common complications include damage to the ilioinguinal, iliohypogastric, or genitofemoral nerves, which can lead to chronic residual neuralgia and post-operative constrictive scar tissue in the surgical area. Hey, look! It's quiz o'clock! Where are direct and indirect hernias located in relation to the inferior epigastric artery? Cryptorchidism is the abnormal or partial descent of either one or both testes into and they can be found. Any of them include testes palpated in the inguinal. A surgical procedure include infertility, malignancy, and testicular torsion. Plexus in either testicle, which is a network of small veins within the spermatic cord. 2 reasons. Due to compression between the aorta and superior mesenteric artery, as it courses between these two structures, resulting in a nutcracker effect. This further increases the intravascular pressure in the left gonadal vein and dilation of the pampiniform plexus. So depression from a right renal cell carcinoma. On examination, complications of a varicocele include infertility due to increased tunica vaginalis of the scrotum and is often congenital. Remember the processus vaginalis? Well, when it fails to close, that doesn't only increase the risk of inguinal hernias, but also allows for peritoneal fluid to flow into the tunica vaginalis. A hydrocele can also be acquired at any age, typically following infection, trauma, or a tumor. Individuals present with a soft, fluctuant, which has a red glow indicating serous fluid in the scrotum. Hydroceles can be precipitated by inflammatory conditions, such as epididymitis and testicular torsion. And complications include transformation into a hematocele, which is a collection of blood in the hemiscrotum, as well as calcification and testicular atrophy. Finally, there's testicular torsion, which is just as painful in adolescence. It often happens in the cord. Typically, however, with prolonged compression, the arterial supply eventually becomes completely occluded, leading to hemorrhagic and vomiting. Elevation of the testicle doesn't relieve the scrotal pain, which is called aster muscle contraction of the cremasteric muscle, and as a consequence, contraction of the scrotal sac. The cremasteric reflex is important in trying to differentiate testicular torsion from other conditions that cause scrotal pain, such as epididymitis, or inflammation of the epididymis, orchitis, which can be caused by mumps, and Fournier's gangrene, which is a necrotizing fasciitis of the genital area and perineum. Diagnosis of testicular torsion is based on physical examination, but a Doppler ultrasound is required to detect reduced blood flow or twisting of the spermatic cord. Testicular torsion is a surgical emergency. An urgent urological consultation and surgical detorsion is required, in addition to fixing both testicles to the scrotal septum to prevent further torsion. If surgery is unavailable, manual detorsion of the testicle can be attempted, delaying both manual and surgical maneuvers needed. Umbilical, Spigelian, irreducible hernias can eventually diastatic femur when there's a separation between the medial sides of the rectus muscles due to a weakened and stretched linea alba. Femoral hernias occur when the hernia sac protrudes through the femoral ring into the femoral canal. They occur more commonly in older biological females and have a higher likelihood of becoming strangulated due to the tight space of the femoral ring. Inguinal hernias are the most common type of hernia in both biological males and females, and they can be direct or indirect. Direct hernias are caused by weakness of the transversalis fascia, where the hernia sac protrudes into the Hesselbach triangle, medial to the inferior epigastric artery, and can push into the superficial inguinal ring, but not into the scrotum. Indirect hernias can be caused by a patent processus vaginalis and occur lateral to the inferior epigastric artery and protrude through the deep inguinal ring into the inguinal canal and may extend into the scrotum. Cryptorchidism is the abnormal or the dilatation of the pampiniform plexus. More often, it occurs on the left side and doesn't transilluminate on examination. It has a characteristic bag of worms finding on visual inspection and palpation. A hydrocele is an accumulation of peritoneal fluid around the testes in the tunica vaginalis of the scrotum and does transilluminate on examination. Testicular torsion is the twisting of the testes and the spermatic cord, resulting in severe pain, nausea, vomiting, and may result in testicular ischemia and necrosis due to restricted blood supply. It is a surgical emergency and requires manual or surgical detorsion immediately.